We shall now go on to our next speaker, Dr. SIRISHA, who heads the glaucoma department at the LV Prasad Eye Hospital and a specialist in cataract, glaucoma, and children's eye care. And we all know she's a very eminent glaucomatologist of our country with her own set accolades and awards. And she is going to take us to a very challenging talk, a consensus on glaucoma management and Sturge-Weber syndrome. On to you, Dr. SIRISHA.
Thank you, Dr. Chitra. It's been wonderful listening to the two previous talks. So let's change gear from minimally invasive to the most difficult condition that we tend to manage. So the objectives of the presentation will be what is it that is different in Sturge-Weber's syndrome and glaucoma? How do we manage them? And the modifications that we do to have a safe surgery and the consensus that we have in dealing with this disease. So not getting into too many details, but to brief everybody that Sturge-Weber syndrome is a type of phakomatosis with an encephalotrigeminal angiomatosis, which means that there is involvement of the facial cutaneous vasculature. There is involvement of the hemangiomas involving the first and the second division of the trigeminal nerve. There is also leptomeningeal involvement, which causes seizures and secondary systemic involvement as well. So we are dealing with a condition where there is systemic abnormalities, and some of them may have mental retardation and seizures that again one needs to be careful before we take it up for surgery. Ocular involvement can have hemangiomas of the upper lid, lower lid, of the episclera ciliary body, and most commonly what we see is choroidal hemangiomas. So the glaucoma in this condition is very difficult to treat. They usually present as two peaks. First of them will present at very early age. That means they can present even with congenital glaucoma. A newborn baby can have glaucoma with Sturge-Weber's or with phacomatosis pigmentovascularis. The second peak usually arises in a little early adulthood, or maybe I would say children in teenage, where that is likely because of the raised episcleral venous pressure. In a baby, if it presents, usually it is because of the maldevelopment of the trabecular outflow pathways. So the time of presentation is very important because depending on when it presents and what the mechanism is, our treatment would vary. So episcleral hemangioma, you can see a picture here, very beautiful network of blood vessels that you see when we open up the conjunctiva in these patients. That is episcleral hemangioma, and that actually poses a lot of problems for us when we operate them. Choroidal hemangioma, very difficult to identify unless we examine both the eyes of the patient, especially if it is unilateral. You will just see an orangish hue and nothing different. So it's important to identify because this is again very important because intraoperatively as well as postoperatively, one may expect complications, much more complications in patients with hemangiomas. So this is just a bright red glow in an eye that is with a pupil dilated in a child with Sturge-Weber syndrome, which possibly gives you a hint that there is a choroidal hemangioma. So often we ask this question, do medications help? Like any other disease, when there is an early presentation, medical treatment does not help and it is a surgical disease. Like I said, most often the angle is dysgenetic if the child is small and that requires a surgery. And if in older children, when they're present, medications definitely have a role to play. What medications do we use? We use in children, depending upon when they're present, we use timolol or a beta blocker, a dorzolamide, or a combination of the same. But in this particular condition, because the problem here is possibly secondary to raised episcleral venous pressure, a mechanism that will bypass the raised episcleral venous pressure that does not depend upon the trabecular outflow possibly is more helpful, which means that a PG analog group of drug may be more helpful in these patients compared to the other group of drugs where especially the trabecular outflow pathway, if you can try and avoid. But when we are desperate, we try and give them all medication. So there's nothing wrong in using them, but it's just to know which of them, if you have a choice of using one medication, maybe a PG analog would be more helpful. Often we require surgery to control intraocular pressure in these eyes. But if I have a child, especially not a baby who presents with glaucoma, it's easier to handle because this eye is not exposed to high pressures for a long time. However, if you have a patient who's older in their teenagers who presents with glaucoma, more often they present with very advanced glaucoma. These are extremely difficult to treat and majority of us try and defer and try to use as many medications as possible to control the intraocular pressure. There are various surgical options that are there. I can possibly take you through a few of them with the tips. So why is it is so difficult to operate these patients? So surgically, I don't think there is much of a difference, except that these eyes can bleed a lot, they can have hemangiomas and things like that. But the other major problems that we are worried about is causing a decompression, because the choroidal hemangioma, episcleral hemangioma, these are all hemangiomas where there is increased blood supply to the eye ocular structures. So whenever we cause a decompression and hypotony, that causes that predisposes these eyes to extensive choroidal effusion and exudative retinal detachment. Shallow anterior chamber, flat anterior chamber is a very common problem, and intraoperative expulsive or a suprachoroidal hemorrhage is again not uncommon. That apart, because of extensive vascularity, there is a high risk of surgical failure irrespective of which surgery that we perform. So just sharing a few case examples to know what kind of problems we are likely to get and how do we handle them. This is a boy who presented with a left-sided port vein stain with unilateral glaucoma, and pressures were well controlled until this age when his pressures went uncontrolled and he required a surgery. So preoperatively, we did do evaluation including the OCT. The choroidal volume was really huge and baby had a diffuse choroidal hemangioma. So we did a trabeculectomy with mitomycin C surgically with all precautions that one can take. So most importantly, we were worried about a choroidal detachment. Fortunately, he did not have that. But what happened on day 3, suddenly there was decrease in vision. So what he had around 2040 suddenly decreased to almost about 2 meters, 3 meters. That is because he had a huge serous macular detachment. So not necessarily that they have a choroidal detachment, they can also present with a vague picture of a serous macular detachment that can suddenly bring down the intraocular, bring down the vision, and that can be very dramatic. So this child was put on oral propranolol, and soon it resolved by about a month. So this was the kind of submacular fluid with a retinal elevation. In about 4 weeks' time, he completely resolved. So it is possible to treat, but what we need to know is reassure the parents that such a thing can happen, but also keep a watch on that. So when there is a drop in vision, make sure that you examine the retina appropriately, otherwise get an OCT done to understand if we are dealing with that condition. And it completely resolved, and his vision came back to 2040 and he was doing fine. One of the associations that we deal with in Sturge-Weber's is a bilateral involvement and a condition called as phacomatosis pigmentovascularis, where there is also a pigmented component apart from the hemangioma that they have. It's one of the most difficult glaucomas to treat, and unfortunately, they present bilaterally and the glaucomas can be very difficult. So this was a boy with this condition. And so what I normally do is preoperative propranolol 2 weeks prior to surgery, huge episcleral hemangiomas. So what we need to worry about is a lot of bleeding intraoperatively. So the good dissection, a careful dissection, a good cautery to the episcleral hemangiomas, pre-placed sutures, and maybe additional sutures to make sure that you're not dealing with hypotony on table, and always make sure that the anterior chamber is kept formed either with viscoelastic or with air, whatever suits you, and make sure that there is no intraoperative hypotony. Some people also use a anterior chamber maintainer to prevent the hypotony during surgery. So whatever suits you is fine, but I think it's very, very important. So with all the adequate precautions that we took, this was the day when post-op. AC was shallow, air bubble that I had left, part of it got absorbed, but these are problems that we know will occur. But what is worrisome is this kind of exudative choroidal detachment. This gentleman was started on oral propranolol 2 weeks prior to the surgery. But this was the kind of extensive choroidal detachment with exudative retinal detachment with vision which dropped to hand motions from 2060 or 2080 that he had. So you don't have to worry. Continue the medications and you can actually see this slowly resolving, and even the submacular fluid resolving, and vision by about 6 weeks improved to 21-25, and his vision was about 2060-2080 prior to surgery, and pressure slowly started going up. And I'm happy when the pressure went up, because that little bit of CD and the exudative RD that is there also will disappear maybe in a few weeks time. Repeat.
1 minute remaining.
repeat interventions is something that we have to be careful about, and they are more prone to having complications in these patients. So this, like I said, phacomatous pigmentovascularis is very, very difficult to treat, and most often the first surgery fails and one may end up needing to do an implant. Again, one can ask this question, is implant better than performing a trabeculectomy? We'll come to that in a little while. So what is necessary is taking a preoperative precautions, doing a careful evaluation, intraoperative modifications for the surgery, as well as post-operative medications and follow-up as and when necessary, I think will go a long way in preventing complications in these eyes. So the surgery that we prefer in early onset glaucoma is a combined trabeculotomy with trabeculectomy. We have shown results that are good over a period of about 64 months. Very minimal chances of complications in these eyes, but yes, we need to be careful as these children have a problem at a very early age. As time goes by, they may require additional surgeries in the future as well. GDDs, I don't offer it as a first line procedure. We still prefer to do a trabeculectomy as the first line. The GDDs do have a role to play in reducing the intraocular pressure. This is a cohort of patients that were published from Sharon Friedman's group, where they also have performed it as a majority of them as a repeat intervention. So what is most important to understand is even with GDD, the complication rates are quite high. Close to 50% of the eyes had complications. So when somebody asks your trab is likely to fail, it's likely to fail, not necessary in all patients, but we also have to worry about the problems, or so the GDD not necessarily are safer compared to trabeculectomy. So safety wise, I think all of them, any surgery that causes a decompression can have problems, but we need to handle them. TSCPC may be used in certain conditions, but we don't do that in a seeing eye. One question that is commonly asked, a question that I have asked myself, do you do your prophylactic sclerectomy in these eyes? Like the non-ophthalmos, I don't do it. There are results to studies that have shown the presence of absence of sclerostomy does not result in excess complications, but there's no RCT for us to really say whether it is helpful or harmful. Propranolol, I think this study from Sushmita's group has been a really landmark paper that has helped us to actually handle these patients with definitely with a little bit more confidence. And so what they have shown also is that oral propranolol is helpful in preventing, or rather helpful in resolving the condition when they have a CD postoperatively. Bilateral cases, repeat interventions are definitely at high risk of developing complications, which may require an intervention. So how does propranolol help? It actually causes a vasoconstriction. So there is a review that had looked at the types of surgeries and to say, is one surgery better than the other? Trabeculectomy and valve implant almost have similar results. However, we need to worry about the complications in these groups. Recently, there was a paper that was published in BJO from a group in Bangladesh. Fantastic results they had shown. In fact, they were too good to believe. And their complication rates were very, very minimal. But remember, these were older patients, like in their fourth decade, which they have managed. But I do not know whether, this kind of results, maybe because they didn't have that severe a glaucoma until their fourth decade, whether they were responding better. But in our hands, our complication rates are definitely higher, although we can handle them better. To sum up, high risk of glaucoma in patients with Sturge-Weber's, medications definitely have a role to play, but in older children. There are problems with surgery, but modifications are definitely helpful to offer a safe surgery in these patients. And even if complications do occur, I think what is important is to recognize them early, the type of complications that they can develop, and treat them appropriately. A bilateral condition, second intervention definitely have high risk of complications. And there's a very limited role of possible prophylactic sclerectomy in these patients. And oral propranolol definitely is helpful to handle the choroidal detachment and exudative RD that they develop in a conservative way. Thank you so much for your attention.
Thank you so much, Dr. SIRISHA. That was a truly wonderful talk. But continuing with the content, since there are two concepts, the angle dysgenesis and the increased episcleral venous pressure, would you think angle surgeries do also have a role to play?
Yeah, so because of the time constraint, I really did not go into the details because we don't perform angle surgeries in these patients. So if we do angle surgery, we do it as a combination by doing a trabeculotomy and trabeculectomy. in a young baby where even angle dysgenesis is likely to happen. But so avoiding the trabecular outflow or bypassing the trabecular outflow would be a preference, and angle surgeries don't show good promise in these patients.
Would you, if you were to use a GDD, would you think of narrowing the lumen?
Not really. That's what I was saying. So whether we use a valved implant or we use a non-valved implant with a fenestration or a very slow decompression, when the decompression happens, even if it means it's a minimal decompression, patients are likely to have a complication. So it could be less, it could be more, but yes, any of these interventions can cause a problem. In fact, a couple of situations where an AGV with a tube ligation is also something that we have done. But even when that ligature dissolves, you will have a decompression. So these eyes are more prone. That's what I think we need to remember. But at the same time, I don't think we should really worry about losing the eye. Fortunately and thankfully, we haven't lost any eyes. Yes, we may lose 1 or 2 lines of vision because of the problems that they deal with, that they have. But if we handle them appropriately, we may not lose vision because of the surgery.
Dr. Murli?
Yeah, madam, what is the dose of propranolol that you typically use?
2 milligram per kg body weight.
And would you recommend a limbus-based flap in these patients for a tighter closure, or is phonics also okay? Phonics-based flap also?
Yeah, so in children, majority of the time, I do a limbal-based, and also in complex eyes, I do a limbal-based, because even a little bit of leak, a chance of a leak is something that you really don't want. And multiple sutures are releasable. So, I mean, it's a personal choice. Many people prefer to do a phonics based with tight anterior conjunctival closure. But I think that's a surgeon's choice.
Thank you. Paucity of time, I think we have to move on, although this is something lot to learn, as these cases have a very challenging post-operative.